This week on the Animal Heartbeat, we are graced by the presence of Dr. Brian Scansen from the Colorado State University. Welcome, Brian, to the Animal Heartbeat. Thank you so much for joining us. We're super excited to talk to you about pulmonary stenosis. And mostly we'll be focusing on dogs, I guess, but if you want to bring some cat stories or some equine pulmonary stenosis stories, feel free. Thanks so much for joining us.
Yeah, thanks very much for having me. I look forward to it. It's certainly a pleasure to join you both.
We all know that we see particular breeds affected by pulmonary stenosis. What are the most common breeds that you see in your clinic presenting with pulmonary stenosis?
It's a good question. It has actually evolved a bit over the years, I would say. The current answer to that question is unquestionably the French Bulldog. Probably greater than 50% of the cases I currently see are French Bulldogs.
Wow, yeah.
Some of that is probably a bit of a hospital bias because some of the interventions we perform. But I think it's true that trend of a bit of a change in prevalence has been something I've observed over the last several years. Going back 10 years ago, I saw quite a bit more English Bulldogs, Terriers, Chihuahuas, mixed breeds, but now the Frenchie dominates.
Yeah, I think we will feel the same way about the breed switch over time in the UK and in Europe. I think there's many more French Bulldogs that we see, and of course those pose particular challenges for us. I think getting a good echo window is hard enough. How do you assess the severity of pulmonary stenosis in these dogs? Not just the Frenchies, but in any breed? What are your top tips for working out, do we need to worry about this pulmonary stenosis in this particular individual, or is it something that we can monitor or consider some medical treatment rather than an intervention?
I think it's a great question. I think the first thing I would say is that the answer to that is almost completely devoid of any evidence. So we have almost no scientific basis for this. So
like all the best decisions we make.
Yeah, exactly. Everything I say following this, will be opinion and nothing more to a great degree. With that said, I think that point is important because, in mitral valve disease, we now have, a good number of papers. Even in some of the feline cardiomyopathies, we have some reasonable controlled studies.
Right.
Those really do not exist. At best, we have retrospective studies in pulmonary valve stenosis. And I think that point should be made first because we really don't have any evidence guiding what we do. So with that said, how do I assess the dog with pulmonary valve stenosis? I do think then, in the absence of evidence, I think we have to weigh several factors to decide what might be the right decision for an individual patient. That decision for me is certainly going to be dependent on the severity of the disease, and we can discuss ways to assess that. Classically, severity is considered the peak transpulmonary pressure gradient, but as we all know, that is subject to some challenges, namely it's a flow-dependent variable. RV function plays a role here, that when RV dysfunction develops, or when we have severe tricuspid insufficiency, or when we have sedation on board, all of these things may impact that measured gradient. So it does start with the gradient. For me, it starts with the presence of clinical signs. So the animal that is syncopal, cyanotic, exercise intolerant, or in heart failure, those do weigh in to my decision making as far as the urgency or necessity of an intervention.
And I think the exercise intolerance is hard, isn't it? Because many of these dogs have had it since birth. So some owners, especially of these brachycephalic dogs, or dogs with comorbidities, we see more and more in the Frenchie, spinal disease or joint disease. It's tough to know if they're exercise intolerant or not, isn't it? Have you got any advice on that, or have you got any wisdom to share?
Certainly no wisdom. I can tell you that I agree with everything that you just said. I think many of these dogs, particularly if we're talking about the Frenchie, do have substantial brachycephalic obstructive airway conditions that do limit their capacity. And we struggle with understanding, if the dog seemingly is a bit exercise intolerant, which of these factors predominates. With that said, I do find there are clients that seem to recognize that this puppy is not as active as other puppies that they've had, or,
Right.
occasionally get the ones where they have multiple animals from a similar litter and they recognize a difference. And so I think while it is difficult to determine the presence or severity of exercise intolerance, at the same time, we probably miss the existence of that finding as well, because both clients are insensitive and perhaps we are insensitive in ways to measure it.
When you mention echo, Brian, and beyond the pressure gradient, as you said, how many measurements, pretty much, how thorough is your assessment in terms of severity? Which other less flow dependent, let's say, methods do you use beyond pressure gradients?
Well, I mean, because of the interest of our group, we do tend to measure VTI ratios and valve areas. But to give you an honest answer to that question, I mean, do I use those much in the clinical decision making? The answer to that is no. So for me, it's presence of clinical signs, the severity of the pressure gradient, and then the secondary remodeling that occurs. And so for me, what is the degree of RV wall thickening? What is the degree of right atrial enlargement? Is there concurrent defects, right to left shunting, tricuspid valve insufficiency? I would say those factor in much more in my decision for or against an intervention than an indexed valve area or something like that.
That's good to know. And then regarding valve morphology, if you start looking at valve morphology, can you tell us how do you prefer to classify different types of valve morphology, different types of pulmonary stenosis, and how much that might impact on your decision to go ahead and dilate these cases?
That is a substantial interest of mine, and I do pay quite a bit of attention to the valve morphology, somewhat in the decision of intervention. But again, for me, it's the clinical signs, pressure gradient, and remodeling that determine whether I need to intervene. The valve morphology really tells me how I should intervene or how I believe I should intervene in a given patient. And so when you start talking about the different morphologies of this disease, there's many different ways that it's been characterized, as you both know. When we look to the human, there's the typical form, or sometimes called the doming form, which seems to predominate in the human. And then there is the dysplastic form. Those terms, to be honest, are not very useful, in my opinion, because typical only means something if that's the dominant form.
If that's the typical form, yeah.
Exactly. And that's, I don't believe what a human physician would call typical is typical in a dog. I'd say much more what they consider dysplastic is going to be within the spectrum that we see on a daily basis. But even that definition is a bit lacking, because on the human side, typically it just refers to thickened and or immobile leaflets rather than fused commissural fusion and doming. And so then you look to, what Claudio Busadori and others have used a type A and a type B. And I think that is a useful system. However, my personal opinion on that is, as I've looked at different papers and or just watched or had referrals from other cardiologists, what one group might call type A, I don't think is always the same as what another group might call type A. If it's solely dictated by the pulmonary valve annulus, as let's say less than 80% of the aortic valve annulus as a measure of hypoplasia, I think that's one definition that you'll find out there. To me, pulmonary valve annulus itself isn't enough to decide what the right intervention or likelihood of success of an intervention will be, although it definitely factors in. Others look at, whether there's poststenotic dilation, whether there's thickening of the leaflets or not. Almost invariably, there's, we don't really measure the valve thickness, but subjectively, almost invariably, there's a degree of thickening even in what would be considered a fused doming valve. So to answer your question, I try and take a more granular approach. And so I do separate out, and we're kind of working on a scoring system at the moment, but I look at what is the valve thickness, and again, hard to quantify, but I try and look at the echo appearance of the aortic valve, compare the pulmonary valve, and decide if there's thickening, and we can add some subjectivity to that, whether it's mild, moderate, or severe. I tend to look at the pulmonary valve annulus relative to the aortic annulus for two reasons. One, is it hypoplastic? But also, I think measuring the aortic valve annulus from a parasternal long axis perspective kind of also gives me probably an upper limit of what I might consider the normal pulmonary annulus should be, even if it is not. So I'm unlikely to exceed a balloon to annulus ratio greater than 1.5 times the aortic annulus. And I might adjust that certainly if the pulmonary annulus is profoundly hypoplastic. But many times the spatial resolution of the aortic annulus is cleaner and easier to measure. And so I do look at the aortic annulus to kind of give me a guide of what my maximal balloon dimension need be. And then I look at the degree of fusion. So do the valves dome in systole? Are they fused at their tips? Or many times what we see is there really isn't obvious commissural fusion of these valves. They're just immobile. They're so thick that they don't really come apart. It almost creates a tunnel-like, what others I think have termed an hourglass appearance. I think that gets us a little closer to talking the same language, although I still think the hourglass analogy has some flaws as well, because sometimes the hourglass is related to fusion and doming with a degree of adhesion at the sinotubular junction. And sometimes the hourglass is caused by a large chunk of fibrotic tissue that exists in the sinus or at the sinotubular junction. So that's also a bit of an angiographic descriptor to me rather than an echocardiographic descriptor, so seldom known in advance quite to the same extent. And then I do look quite closely at the sinotubular junction. And this is something that I think is more difficult by echo than it is certainly by CT or TE or angiography, because I think many papers, in my opinion, have classified fibrotic tissue at the sinotubular junction as a supravalvular stenosis. My opinion is that is not supravalvular stenosis. That is within the complex of the valve.
Yeah, I'm guilty of that myself. And I remember you speaking about it and I thought, oh, I better read about that and check. And so I don't use the term supravalvular now in the same way. I talk more anatomically and specifically about a fibrous lesion at the sinotubular junction because that's what it is. And then the terminology, we don't get bogged down in what's valve and what's not.
Yeah, that's right. I mean, I think I've spent a considerable amount of time trying to sort this out, from human anatomy and kind of looking at a lot of dogs. I wouldn't say that there's consensus anywhere, but it does seem to be in the human that the valve exists from the right ventricular myocardium, where it terminates at the annulus, to the origin of the pulmonary trunk, which is at the sinotubular junction. And therefore, the sinotubular junction belongs to the valve. And therefore, disease of that area is all within the spectrum of valvar stenosis, in my opinion.
Yeah. So I think we're not looking at an arterial disease. We're looking at a valvular disease.
Exactly right.
I would agree. Yeah, it's I think it's important we try and talk the same language, and I wonder if it's something that we need to think about a consensus statement for, because it's an area that, with the evolution of ballooning into different procedures or augmented procedures, high pressure balloons, cutting balloons, stents, over the past decade or more, I think it's important we try and get on the same page and treat the same patients in a similar way. And at the moment, I think people are doing things differently, aren't they? And you talk to some people and they still talk about type B pulmonic stenosis, and I don't really know what that means. That doesn't give me enough information. And I think Claudio's paper and the statement there, the sort of AB types that he described, was great at the time, but I think now we've seen different breeds. We see more Frenchies, we see more disease of the next levels in that valvular region, the sinotubular junction, and I think that's just complicated the issue.
The only comment I was going to make in addition to that is the ecosystems have improved since those original papers. Our visualization of this area is better. And then what has really changed for me is the use of cardiac CT. I mean, I think when you start doing cardiac CT on these patients, you see the full spectrum of the outflow tract and the pulmonary trunk, and you're not limited by two-dimensional acoustic windows that in these breeds particularly can be challenging.
Very challenging, yeah.
So
that's super interesting.
Reconstruction changes how you visualize this valve, in my opinion.
On echo, what I feel sometimes is, except on the two sides of the spectrum, it's always very difficult for us to predict how the valve will respond to ballooning. And we'll be discussing a lot about different types of ballooning and so on shortly. But do you think CT will help you with that? Because sometimes we see very ugly valves, these plastic valves that still respond really well to high pressure balloon, and other valves that we thought maybe there is some degree of fusion that will respond and doesn't respond. Do you think CT helps you kind of predict which valves may respond better to standard ballooning or high pressure ballooning?
I think it's a great question. I guess my answer to that would be CT clearly helps me understand better the morphology of the valve that I'm looking at. Now, the next step to that is, does that understanding improve my ability to prognosticate who is going to respond to balloon? I don't know that I can answer that in all fairness. I will say there's a degree of selection bias in that when I look at a very thickened valve with substantial fibrotic tissue at the STJ or in the sinus itself, fairly or unfairly, I advise the client that balloon dilation is unlikely to be of substantial benefit here. And that may be true, it may not. I don't have solid data to support that other than, 20 years of experience ballooning these dogs. And so we have this conundrum now where I think I see things much better by CT. That dictates my decision making. And then I confirm that bias by those patients receiving a stent. And so I think it's a great question. It'd be nice to look at that more scientifically and try and make that determination. But what I would say is CT, particularly in bulldog breeds, allows visualization of the valve that is simply not possible by echo.
It's cool that, of course, your experience that you have been doing this for 20 years, because my point was exactly what you are saying. I think very quickly now we'll jump into a stent, the transpulmonary stent, because we can, but then is it better? Because we will not know if the valve would have responded to balloon dilation. Of course, then we have an implant versus no implant. But having said that, of course, is the risk of failing a ballooning and then a second intervention and the cost of that second intervention versus hopefully with a stent to solve the problem. But do you feel then, considering that you have been doing this for 20 years, when you didn't have stents available and those ugly valves that look fibrotic and so on, how many of them would respond? Or any tips if a stent is not possible that you would feel, okay, this valve may still respond, or that's just completely unpredictable?
I don't think it's completely unpredictable. I do think it's challenging. So I would say a little bit of the journey for me is, in my residency and shortly thereafter, exclusively we used, Tyshak balloons, what would be considered low pressure balloons. And my anecdotal experiences, those worked perfectly well for valves that were relatively thin with a normal size annulus that domed in systole. And probably had mild or minimal fibrotic adhesions at the STJ. I think somewhat interestingly, either I've gotten better at recognizing more of the spectrum, or as we alluded to earlier, the spectrum of disease has changed as the French bulldog becomes the dominant lesion. We certainly ballooned some English bulldogs early on, in at least my experience, where we used Tyshak and other type of low pressure balloons and didn't feel like we made a heck of a benefit in those patients.
I think most cardiologists feel the same way about, these patients historically. Yeah, for sure.
And then, as things kind of moved towards the high pressure balloons, and that was probably, I don't know, I would say in the 2010s, in that kind of range, I feel like we saw benefits in some patients that we didn't see with the lower pressure balloons. So I think there was an additive benefit to using high pressure. Right. Again, that's an opinion, not really based on science, but anecdotally, I'd say that's true. But then what I would say about the French bulldog is when I would balloon Frenchies with high pressure balloons, it's exactly as you say. Sometimes the result is a little better than I expected. Sometimes I thought we'd have a decent result and really we did not. But what was almost invariably true in my experience is the result would not be durable. And so I might balloon a Frenchie, then a year later, almost without question, his gradient had increased, not always to the same severity, but still usually to a severe, if you want to use echo as the gold standard of severity, to a severe level of obstruction, greater than 80, greater than 100, what have you. So the rationale for now, kind of when I see a Frenchie with an ugly valve, I advise the client to move to stenting fairly quickly. And usually it's because in the past, either I had no benefit with low pressure, moderate, but not a durable benefit with high pressure. And the hope is that stenting might provide both a better result and a more durable result.
And it's important to make the right choice there, isn't it? Because for many of these owners, you've got one shot.
Yeah,
you've got one financial support, effectively either through pet insurance or just through their own funding or crowdfunding, more and more actually. You've got one attempt. And if that doesn't go well, it's a real shame. And everyone feels a bit sad about that. In terms of the decision making, I think we've all changed how we approach those cases.
I very much agree with that. What I would say is the first few stents that I put in, I would always caution the client, standard of care is a balloon. We should do a balloon, and then we might have to come back. And it's exactly as you said, the level of guilt that I experienced when that result wasn't good was troubling. So then I moved to, okay, we're going to balloon your dog, and immediately in the cath lab, if I don't like the result, I will move to a stent. The one comment I would have about that is, at least in theory, if you dilate that valve, you potentially alter the landing zone of your stent, and maybe there's a theoretical risk or greater risk of stent dislodgement if you have recently dilated immediately previous. So with that, I've moved away from that offering as well. So now my conversation to the client is either I think this is a balloonable valve, in which case if we can avoid an implant, that's what we should do, or this is not a balloonable valve, and then your option is stent. And I basically leave it as those two options.
Yeah, and I think stenting is not intervention 101, and there are many cardiologists who'll be fairly happy to do a balloon, but maybe not place a stent. And I'd be supportive of that because it's an implant. If it goes, it goes. If there's a problem halfway through deployment, you've got to troubleshoot that. And I think it can be super challenging. I was going to say, just briefly, let's take it a step back and think about our criteria for judging success. We've talked about likelihood of a good outcome for these patients who are undergoing a balloon valvuloplasty, and if you think it's likely to be good or not. What is a good outcome? How do you define a good outcome from a balloon?
Well, good outcome from a balloon is the dog lives a normal life and doesn't die of their pulmonary stenosis. Unfortunately, we don't have that data.
The crystal ball's not calibrated.
Exactly.
Yeah.
Exactly. So I think this is where you have to take some extrapolation from the literature. There's, as you know, there are some papers, that at least have looked at dogs that did not have a balloon as compared to those that had a balloon.
Sure.
And those would suggest that a pressure gradient of around 60 in one paper, maybe 80 in another paper, suggest that dog, at least the risk of a cardiac related mortality, if their pressure gradient is below 60, let's say, is lessened and probably, maybe not identical to the normal population, but not too far off. Whereas the more the pressure gradient increases above that threshold, the greater the risk of a cardiac related mortality. And so for me, that's kind of a threshold that I would like to see. Now, certainly the lower, the better. I'd love to get it to normal. I mean, a physician would be happy less than 30. That's probably unrealistic, or at least it has been in my experience. But if I get it to under 60, I consider that to probably have a benefit for that animal's lifespan. But then you do run into this question of what is the durability of the result? Because I think oftentimes we look at the 24-hour post-cath echo and we say, great, have a good life. And certainly those animals continue to be followed up, although in my practice, a lot of times they go back to another cardiologist to be followed, who maybe doesn't measure, envelopes exactly the same way, or maybe the dog's, stress level or hemodynamic status changes at a subsequent appointment. But I do think the short-term effect of the balloon is one measure, but probably it can't be the sole measure, because we do see certainly in balloons, even in stents, an increase in pressure over time. And knowing what to do in those patients, I think, is challenging.
Have you got a feel for the rate of restenosis for, let's say, a classic valve leaflet fusion? Do you think it's around the 5% that I think is out there in the literature, or do you think differently? And is it different for the Frenchies and these other more complex morphologies?
I'll answer the second first. I do think it's different for the more complex morphologies. I think if you tear a fused doming valve, those dogs tend to do rather well. I wish I saw more of those. We just don't.
Yeah, sure. Yeah.
I don't know that it's 5%. Actually, to my clients, I tend to quote 15%, and that's somewhat personal experience, somewhat my reading of the literature, that there is, a 15% chance that this will recur. But I think that the definition of that is fraught with challenges as well. So what is a recurrence? What is a suboptimal result? I think that's difficult. I do believe that the patient with pulmonary stenosis tends to reflect some of the lowest pressures on the 24-hour post-cath echo. And then almost invariably at 1 month, at 3 months, at 6 months, there's some fluctuation. Sometimes it's pretty close, but it's seldom lower. And that's slightly at odds, at least with what I was taught a long time ago, is that, you create edema in the valve and you balloon it. It might be thicker originally, and you might actually not see the true result for another month or two, with the somewhat implied thought that if it's edematous after a ballooning acutely, that it might get better as that edema resolves. I don't see that personally. I see it, if anything, worsen over time.
It's so interesting you say that, because I was taught the same thing. Oh yeah, they get edema and inflammation. It's tissue, it's biological tissue. You damage it, it gets swollen. And I've taught people that in the past, but I don't think I believe it anymore. It's really interesting you say that, because I've started echoing them following day, following morning before they're discharged, and then we see them at 1 month routinely. It's always higher at 1 month, not much, but it's never low. And that's just very interesting to me.
The restenosis rate is really interesting, because I always thought was quite low. And now, the recent data from you, Brian, and others, and from Winter et al. That showed rates up to 38%, 20 to 38%. I was like, wow, that's huge. And then, of course, depends on how you define the criteria and so on. And but then that was like, no, this can't be true, or we don't see that. And now we just recently looked at our own data in 2 or 3 centers here, and we have exactly the same, being very careful with the criteria, just looking at the follow-ups, the long-term follow-ups, 2-3 months after. Indeed, it increased, and we had very similar prevalences, which is interesting. It's the classic example. If you don't look at it, you don't see it.
You don't find it. Yeah,
exactly. But what I think then is really challenging. You just told us how would you decide when to intervene, but then how do you decide when to re-intervene, to go in again? So even if the pressure is increasing, but where do you draw the line? What do you use to decide, I will now put a second stent, or I will now stent these guys, or what are your criteria?
Well, I think it depends on what the first intervention was. So my criteria do change a bit if it were a balloon and that has now had an increase in pressure, and as compared to whether it was a stent that has now had an increase in pressure. Some of the same criteria that we mentioned before are relevant. I do think, the pressure gradient matters, but again, how is the RV handling things? Is there right ventricular wall thickening, right atrial enlargement, right ventricular systolic dysfunction? All of those things weigh into it. I'd say a common scenario is, let's just make a hypothetical case. A dog comes in with a pressure gradient of 130, and he receives a balloon or a stent, and we get that down to 50 on the 1 day post, and then maybe he doesn't get followed up for a few months, but at 3 months he gets an echo somewhere, and it's 80, and the question is, do we do anything there? Well, then the next questions to me are, does he have any clinical signs, and how is his right heart handling all of this? And if you have the ability, if you're the one following these serially, and you can actually pull up the first echo, pull up the recent echo, I do think it's sometimes very informative to just get a subjective assessment of, has the right heart Is there more septal flattening? Is the left heart underfilled? Those types of things are clues to me that suggest to me that this is still hemodynamically of importance for this patient, certainly the presence of clinical signs if they're present. If you don't have that luxury, then, an 80 is not necessarily something I'm going to jump to intervene, but that's where what was done before. If it was a ballooning case and I see a clear fibrotic lesion at the STJ, that's probably a case I might suggest to the client, we could probably do better with a stent. If, however, it was a stent previously, then, my likelihood to re-intervene is not high unless I see an obvious target. And I do think the evaluation of the post-stent patient is a bit different, because my experience with the stented dog is that when there is obstruction, it is no longer at the STJ and in the valve apparatus itself, because I've addressed that. And that is, I think, the benefit of the stent, is that it can physically hold things open at that area, which the balloon may not be effective in relieving. What the stent is unable to do, though, is deal with the immediate subvalve region, and particularly the RVOT. And particularly early on in our experience, when we would just center the stent on the valve annulus, you would have half of the stent in the right heart, right ventricle.
Right.
And in that case, I think you almost open yourself up to a risk of compression and fracture and complications. So if that patient now has 80, 100, 120 gradient post-stenting, and it's all the RV, why is putting more metal in there going to be beneficial? To me, unfortunately, that's either now a surgical case or, aggressive beta blockade in the hopes that we can have some benefit.
We've found the same in our population of stents over time. I think I've done about 50 or so, I guess, between here and another center. And we found that some of them have either had crimping, crushing of the stent because it's too low. And those were the earlier cases. I think over time, if you look at my post deployment angiograms, they're getting higher and higher as I've got more confident to leave more out in the main PA and land it better in relationship to that RVOT. But I think the dynamics in the RVOT change over time, because obviously you've got free pulmonic insufficiency. You can then get right ventricular dilation. You can get functional abnormalities, which of course might change how severe that is. But it's fascinating to see these cases over time and kind of learn along with how they're developing. Because I think we're all very much on that learning curve.
I really like you to talk about how that you assess RV remodeling and LV remodeling. I think that's really great. Because of course it makes a lot of sense instead of just looking at one value. In that regard, how much pulmonary regurgitation on stent case will have an effect on your RV remodeling? And did you ever have problems? Are you ever worried with severe PR? Because then, theoretically, then we have a pressure overload heart that then on top we have a volume overload challenge. So we have increased preload and afterload. Is that ever a problem? Do you see cases where PR might then be a problem?
I believe it can be, although I think the issue of pulmonary insufficiency in a stent is perhaps a bit overstated, or it's more of a concern than it needs to be, is my personal opinion. And there's a few reasons for that. Number one, the right ventricle from an evolutionary perspective is a volume responsive chamber, right? So with changes in preload associated with breathing, with fluid shifts, things of that nature, exercise, the right heart handles that very well. What it doesn't handle well is pressure, which is what the left ventricle is evolutionarily developed to deal with. And so I do think if you were going to look at which of these loads is the greater concern in the right heart, pressure overload is worse than volume overload. And you can just anecdotally look at the dogs with tricuspid dysplasia. Certainly they don't tolerate it for a lifespan, but they have wide open tricuspid valves and will live to 3-4 years of age, really until they go into AFib before they really show severe signs. And so I do think for the right heart, pressure is the greater enemy than volume. That's number one. Number two, the capacitance of the pulmonary vascular bed is such that with each right heart ejection, that blood carries by momentum that column all the way out into the pulmonary vascular bed. It's a low resistance system, almost exclusively low resistance in dogs with PS, although I have wondered for some time now that we see all these brachycephalic dogs, chronic hypoxemia, particularly where I live at altitude, whether pulmonary vascular remodeling could be more of a problem. But to your question, I haven't really at least been able to tease that out or see it more clearly. But in general, the pulmonary vascular bed can receive that volume. And at least Charles Mullins in his books talks about the fact that 85% of that blood, basically just by momentum, continues to move out into pulmonary circulation. And so there's a small volume that even would be able to regurgitate. And then when it does, it comes back at a low pressure, given the low pressure and the low resistance of the pulmonary vascular system. And then you add to that fact that you have almost invariably a fairly stiff right ventricle. And again, when I'm stenting a patient, I do worry probably the most about the risk of compressive forces on that stent. So in fact, for me, giving a little more volume to the right heart to open up the outflow tract paradoxically may not be a bad thing, as far
maybe it's
as
protective.
Exactly, limiting some of the compression that will happen on that stent. So those are all the reasons. And then last thing I would say, even in the human, if we use the human model as an example, in the tetralogy patients that have a non-valved conduit after repair, that have resection of the pulmonary valve tissue and wide open PI, those patients, so long as the afterload is relieved, the obstruction is relieved, those patients live to their third or fourth decade of life before they have problems. Well, if dogs live to 30 or 40, then maybe I would worry about PI.
That's a case report in itself.
But I don't. Yeah, exactly.
Yeah.
So those are all the reasons why I'm less concerned about pulmonary insufficiency. But to your question, have I seen it be a problem? I think the answer is yes. And I think the case where I worry about stenting in particular is the dog that has concurrent tricuspid valve dysplasia. I think if both valves are severely incompetent, that is going to be more problematic. And classically, those are the dogs that present to you in right-sided congestive heart failure with severe pulmonary stenosis, severe tricuspid insufficiency. And the debate is, if I think it's a stenting valve, meaning I don't think balloon is going to open it, we have stented several of those. I wouldn't say, that we have seen miraculous benefits in that population. And I think it's because if you can't concurrently address the tricuspid insufficiency, then the increased volume load of PI means that the right-sided failure continues to be a problem.
That makes a lot of sense.
Yeah, you mentioned beta blockers, and this is going to be a good question.
I feel like the specter of beta blockers has been hanging over this conversation, and it was on my mind to mention it as well.
And I just hope you guys have different opinions, considering your recent data from Bristol, Kieran. When do you give beta blockers, Brian? Pre-ballooning, in which cases do you start beta blockers? What doses? And what I would be also very interested on is, do you ever remove beta blockers? Do you ever take them down? So when you have a successful outcome, or what criteria do you use to taper them down and take out the beta blockers?
I think it's a great question. Well, I'll answer your question. What do? I put everyone on a beta blocker. So that's the short answer to your question. I'm less concerned about the ballooning dogs, to be honest. I am not of the opinion that a beta blocker, is going to dramatically prevent complications during the procedure. I think the data from Bristol showed that. I think anecdotally, that's been in others' experience as well. And that's because the suicidal right ventricle, is actually an exceedingly rare phenomenon in veterinary medicine.
Much more common with the
that
stents,
more commonly,
though, I think.
Maybe you could make more of an argument for preoperative beta blockade to limit that.
Do you think you've seen that more with the stent population than the balloons?
Maybe depends a little bit on your definition. I will say we have certainly seen greater instability under anesthesia. And some of it, I think, reflects the fact that we're treating a more severely affected population, particularly these Frenchies with horrendous outflow tracts. Because historically, a lot of those we wouldn't even take to balloon. We would just say there's no option here. And now that we take them stenting, they're more problematic under anesthesia.
We push them harder, right?
Yeah, exactly. And then you put a long sheath, large sheath in there, and you cross the valve, which, maybe is obstructive, to a good portion of it. So I guess I would say, do I see dogs under anesthesia develop substantial hypotension and or profound hypoxemia if they have a patent foramen? We see that more than we did previously. I think it's somewhat reflective of the population, and then the intervention is a little more, involved, and there's more obstructive stuff in the heart at the time of cath. To me, that's not really the suicidal RV. The suicidal RV is everything is fine until you relieve the afterload, and then everything goes to pot. And that I don't think is common. We've seen it for sure, but I think it's far and away the exception rather than the rule. So getting back to the question of beta blockers, I don't, if I could absolutely predict who was going to have that, maybe I would be more selective. The reason I use beta blockers is, again, it gets back to this question of I'm trying to limit the compressive forces on a stent, because now most often I'm stenting these patients. And, obviously Kieran's paper didn't look at stenting, really, it was ballooning patients. And so I do think that's a different population and a different rationale for the use of beta blockade. And then to your last questions, do I ever take it off? The answer is yes. If I get a very good result, and then over time we see reverse remodeling of the right heart, if the wall thickness is normal or close to normal, I don't see any rationale for a beta block at that point. That's probably also a minority of patients where, we are happy enough with the right heart over time. And those are almost always, again, the thin doming valve that open nicely with the balloon, that eventually, yes, we taper off their beta blockade.
A question for both of you. Do you have medium-term, long-term data on dogs with anomalous pre-pulmonary coronary arteries that you have stent? How do those behave?
Brian, you go for it. You're the guest.
Sure. I think in our data set, we are at 8 now with a pre-pulmonary course. I think 2 of those were single left and the rest were single right. My experience with those is they tolerate a stent just fine. So all 8 of those received a stent without overt complications. We have followed, I think the longest is probably in the 3 years-ish out and still doing well. I don't think any of them that I can recall off the top of my head have had, clinical complications or clinical decompensation, but it's probably a little early to say. So in a medium term, 1 to 3 years, my experience has been you can stent the pre-pulmonary coronary artery in both the English and the French. Bulldog, I think those are all the breeds were either English or French. No, 1 Shih Tzu actually. So yeah, I think it's doable. I think, I don't post-dilate those, obviously. I really stick to 1-to-1. I also think the CT is helpful there, so I know what 1-to-1 really is, rather than kind of guessing off an echo measurement. And then obviously to make a diagnosis, CT is helpful as well. But Kieran, what's your experience?
Just to mention, I remember looking at some of your CT images in the past, and you can really define the distance between the coronary and the pulmonary annulus. And some of them are really tight, and some of them are not so tight. So you've got a little bit more sort of a forgiving case. That was super interesting, I think, to me. And I think cardiac CT is a whole other thing in our toolbox we can use to try and assess these patients. The difficulty with it is cost implications, and also my anaesthetists always get a bit unhappy if I say, well, we're going to CT first and then we're going to go to theatre, and actually probably the way that I'm going to do it is actually have them CT the day before and move to theatre. And I think that's the way that some other centres do that as well. I don't CT them as standard at the moment, but I think it would be very useful to do that. In terms of number of cases, I can't tell you an exact number that I've done the stent on a pre-pulmonic coronary. They've all, as far as I know, been R2A. I want to say around 10 or 11 cases. I don't know. I seem to receive a lot of them after we published our paper, where a couple of cases were pre-pulmonic coronaries. I've got outcome on some of them. Wow, when was the first one that I did? The first one I did was 2018. So I guess we've got 5-year outcome on that dog now. And actually he's alive and doing great. I think there's 2 different types of case that we see with these pulmonic stenosis and a pre-pulmonic coronary. I think we've got the ones where they've got a very sort of hypoplastic main pulmonary artery, plus or minus long leaflet tissue, plus or minus supravalvular. I'm so sorry. Sinotubular ridges. I don't say it anymore. Listen to me. It's like such a slip. So yeah, these sinotubular ridges, and I think they're quite easy because the walls of the artery are basically parallel, and you've got a lot of tissue in there that'll hold your stent in, and you go and put in your 10mm stent in a 9 or 10mm artery, and you can be pretty happy. You don't need to worry about post-dilating or particularly positioning it. And then I think you've got ones in the English Bulldog, mainly, the ones that I've seen, and I can remember the dogs very well because they're kind of nightmarish. I've had some really challenging cases where the annulus is very, very small, at 8 or 9mm, and then it flares into these huge, broad main pulmonary artery of 12 or 14 or 16mm. And they're really, really hard, those cases. Those are ones where really you I think, should coronary stress test. So look at the effect of inflating smaller balloons and upsize your balloon and see what happens to your ST segment, your heart rate, your output. We do look at visual change. We'll cut down on the femoral and do an aortic root injection or a coronary injection for those cases to look at the rate of flow more than a pacification through that coronary artery. Because if the rate of flow slows down when you've got a 10mm balloon inflated, you probably shouldn't be using a 10mm stent because you're compressing the coronary. They're tough because I worry then that you effectively have a stent held in a ridge of tissue that's quite narrow, that's wobbling around in this large RVOT and large PA. And I worry about that being very unstable. So I've taken to sort of flaring those stents like an hourglass to follow the hourglass. But it's really hard because the step up from the annulus to the wall of the artery can be a sudden 4mm step up. And you can't get a stent to do that very reliably. You can sort of smooth it. And that makes me feel like it's a bit more secure. If it's an hourglass, it's not stretching the coronary, but it's being held in place because you're trying to conform to the walls of the artery. And I would hope that promotes endothelialization, although I don't know. They're really hard. So they end up as cases where you stress test the coronary, you deploy the stent, and you sweat it as you deploy, and you worry in case you've got it wrong. And then your stent's kind of hanging with a wire through it. And then you play with different size balloons and manipulate those balloons in order to try and get an appropriate flaring. The cases I've done have all gone great. I remember one, I went to another center who'd a very experienced interventional center, and they said, "Oh, we have a really difficult case. Do you want to come and help?" And I said, "Oh yeah, sure. I've done these cases. I can come and help." And we lost 2 stents out in the MPA. We had to push them out into branches and balloon them up into the branches to secure them. We used a 3rd stent. We got it in, but only just. It was a hard day. Dog's doing fine, but it was a tough procedure. And of course, that was the one I was like demonstrating my skills at another center. So, it's all of those ones go wrong. But they're tough, I think. Do you identify those differences, Brian, as well? Or am I just making this up because this is something that I've seen and imagined?
No, I agree with that. I think, and it is the English that is more problematic. Yeah. Usually the Frenchy, it's not much different than a typical pulmonary valve stent, to be honest.
No.
A couple quick comments. Number one, the other thing I think, so I have a grad student looking at the coronaries in all of these dogs, because we have about 75 CTs of PS that have had stents.
Right.
And so what I think we also need to be aware of in the human, it's not solely the pre-pulmonary course that is problematic for stenting. Normal coronary ostia can be associated with compression. And by some of the Melody and the Harmony valve data, if the coronary is within 2 millimeters of the annulus of the pulmonary valve, and usually it's the left main in that population, then or the periconal, then that can be problematic. Well, I will tell you that almost every French bulldog, the left main is within 2 millimeters of the pulmonary annulus, and so I think we don't know what we're doing even in dogs that have normal coronary anatomy, and so we're starting to at that, although thankfully, knock on wood, I have not recognized, massive coronary occlusions. And then to the question of the pre-pulmonary course, I agree with you. It's the English Bulldog. I'm not personally convinced how much we have to flare. I think there's often so much dysplastic tissue there that I think that that stent is going to hold. The concern for me is in the English Bulldog at 10 millimeters, that's seldom the size of the annulus I would like the English Bulldog to have. And so I just don't know how much we're doing. I think we're doing something, but are we helping them enough to justify the cost and the risk of the procedure? I don't know the answer to that.
Yeah. I've got a final couple of questions before we wrap up, actually. The first one is, do you think there's a place for cutting balloons in pulmonary stenosis intervention? And the second question is, where does surgery fit in now? Do we need the surgeons anymore for this? Or are we moving, to just this being an interventional procedure?
So great questions. To the first question, the answer is almost exclusively no. I don't think cutting balloon has a place in this disease with the presence of stenting. The exception to that, and what we haven't talked about, but it gets to the earlier question about nomenclature, which I think is, maybe I'm more obsessed with than I should be, but I do think it's important that we talk the same language.
It's super
when you
important.
talk about infundibular stenosis, when you talk about double chambered right ventricle, I do think, and I still use cutting balloons in those because I cannot stent within the lumen of the right ventricle.
Right.
And if that is a fibrotic lesion, I have seen better benefit with cutting first and then high pressure dilation. So, but that is not valvar pulmonary stenosis. In the valvar pulmonary stenosis, no, I can't remember the last cutting balloon I did. It's probably in the series that we published before stenting.
Sure.
I do think surgery plays a role because I think there are cases that I am unable to effectively treat. And the classic example would be more when the lesion is immediately subvalve or the RV is so completely thickened that there's complete cavity obliteration and there's almost no way that I can land a stent without engaging some of the distal RV. Those cases, I do still currently stent many of them, but I usually caution the client based on where I know the stent is going to end up. Either I'm going to be completely in the pulmonary trunk and you're still going to be obstructive, or I'm going to be in the RV to some small extent, and likely we're going to be dealing with compression and all those complications. So I do think surgical resection can play a role there. I think the unfortunate thing is, as this has become an interventional procedure, we have fewer and fewer surgeons who are comfortable with an approach to the RV outflow tract in veterinary medicine. And I think what it becomes then, unfortunately, a self-fulfilling prophecy. If the risk and cost of surgery, greatly exceeds the risk and cost of an intervention, even an intervention that we kind of suspect will not be terribly beneficial or successful, many clients will still select the intervention, and therefore we have even less cases that end up going to surgery to give them, the caseload that they need to grow their skill set. But I do think there are cases that are surgical. Unfortunately, they seldom get surgery.
Right. Maybe one last question, Brian. So a nasty but quite interesting complication, I would think. So pulmonary edemas, pause ballooning. Have you seen them? What do you think the mechanism might be, or more interesting to us, maybe, when are you worried about them? In which case you might be worried that these dogs might develop pulmonary edemas?
For me, it's the tetralogies. So to me, I think if you have severely underfilled lungs, so severe pulmonary hypocirculation, that patient, if you restore even close to a normal degree of pulmonary blood flow, I have seen those dogs have complications. I think the other case reports that are out there of a very nice balloon all of a sudden decompensating into a severe pulmonary edema, I think that happens, but that's probably even less common than a suicidal right ventricle. And I think you might predict a perfectly nice thin valve with a gradient of over 200. That might be a dog that's at risk for that. But even those, oftentimes, they just do fine. There's no problems. And so I don't know that I have great ways to predict who might develop pulmonary edema because I think it's exceedingly rare. But it would be the case that you take from 200 plus to 20, in my experience. The greater issue, I think, is when you have a VSD NPS, or when you have tetralogy, when I have tried to stent those outflow tracts, it is exceedingly difficult to know how much you can open it without flooding the lungs, both because the VSD flow may now switch to more of a left to right dynamic, but equally, those lungs have never seen a reasonable volume. And those lungs, I think, do not tolerate a return to normal blood flow.
Thanks very much.
Interesting stuff.
Brilliant. So I think we are reaching the end of our podcast. Brian, thank you very much for joining us today. It has been a true pleasure, really. To finalize, give us 3-4 take-home messages that you think are really important for practitioners out there or cardiologists regarding pulmonary stenosis.
Yeah, well, first, thank you for the opportunity. It's really been a great discussion, and I appreciate both of your time. As far as take-home messages, for me, pulmonary valve stenosis, I think, is now the predominant congenital heart defect of the dog. And there are some studies to back that up, but I think future studies will show that to be even more the case. We see this disease more and more commonly, and whether prevalence is changing or breed prevalences are changing is maybe a matter for debate, but this is common. And I think that the practitioner needs to understand that it is common. With respect to treatment, I think the take-home message is that treatment for this disease is evolving, and it is no longer sufficient to simply say he has PS and therefore needs a balloon. To me, we have to do better at understanding what forms of PS the dog has, and that includes multiple ways of assessing the morphology of the valve, as well as the secondary remodeling to the right heart and the right ventricular function. I think all those things should play a role in how we assess a given patient and decide how to intervene and how we follow that patient over time. And then the last I would say is, with those two issues, both prevalence of French bulldogs and other breeds that have more dysplastic forms of PS, and with a better understanding of valve morphology, in my opinion, aided by cardiac CT, we probably need to consider stenting, refinement of that procedure, and or consider newer therapies that may better address the very thickened, fibrotic, dysplastic pulmonary valve.
Great.
Thanks so much, Brian. That was super interesting. And thanks to everybody out there for listening.
Thank you.
Thank you, everyone. Don't forget to follow us on socials, our podcast, The Animal Heartbeat. Our handle is @heartbeat_pod. See you later. Have a great day.